Welcome to Nurse Practitioner Week. I'm Dr. Irma Jordan, Clinical Director of the Family Nursing and Psychiatric Mental Health Nursing Programs at Frontier Nursing University. I'm happy to welcome the following presenter, Lindsay Burson, DNP, APRN, and Family Nurse Practitioner. Dr. Burson completed her MSN and DNP through Frontier Nursing University. She has been a family nurse practitioner for 7 years and is a member of Sigma Theta Tau International. She has served as a medical missionary in Guatemala and South Africa. Her U.S. practice has been focused in federally qualified health centers with migrant populations. She is very passionate about care to families and underserved populations. She's excited to begin her new role as faculty teaching community health nursing.
Thank you for the introduction. As a two-time Frontier alumnus, it's a great honor to participate in this week's event. On a personal note, the title of this week's event is especially meaningful to me. I've lived as a medical missionary both in Guatemala and South Africa, and Frontier Nursing University provided me with the skills and expertise to answer the call and be mission-focused. Today I'll be discussing my DNP Quality Improvement Project, Family-Centered Care in a Rural School-Based Health Center in South Africa. The 6 aims of healthcare improvement recognize that our care must be patient-centered in order to better meet patient needs. Patient-centeredness focuses on the individual patient's values. It respects the needs of the patient and the family, and it also involves them in the care process. Taking it one step further, in a pediatric setting, patient-centered care becomes family-centered care. The family is integral to the child's health and development. So family-centered care promotes a partnership with parents, guardians, and the patient. It builds on their strengths and empowers them to make informed choices. This is very central to Frontier's mission of primary care focused to families. This is my personal inspiration for family-centered care. This is my family. Being a mother has really opened my eyes to how difficult parenting can be. We as nurse practitioners have the unique and beautiful opportunity to support families as they raise the next generation. And this was my professional inspiration for my DNP project. Our school-based health center was in its infancy, serving over 830 children from 2 established private schools in a previously disadvantaged area of South Africa. Over 250 children were under the age of 6. Studies have shown that in South Africa, families have a deficient knowledge of early childhood development. It's difficult for parents to ask questions about their children's health, and nearly 80% of families were not included in their children's healthcare decisions. Providers even aren't aware of the health education included in a child's medical record. We were curious if the national problem was also seen in our local setting. We conducted a school report audit, which showed the reports to be highly subjective without clear guidelines for assessing normal development. We also conducted a parent survey, which revealed that half of the parents had questions or concerns regarding their children's growth or development. We used a cause and effect diagram, which you see on the screen, to determine what was leading to the preschool parents not being informed about their children's development. We were a new school-based health center. We didn't have a wellness visit model. We didn't have family-centered care in place, nor health education prior to the intervention. Our services primarily were first aid, a sick bay, and vision screening, but with the plan for implementing primary care services. We do know that children in developing countries are at risk for cognitive and physical development stunting linked to deficient care. They have a failure to reach their cognitive potential, which can perpetuate the cycle of poverty. Anticipatory guidance is family health education, which promotes healthy development socially, emotionally, and cognitively. The Bright Futures Guidelines from the American Academy of Pediatrics are evidence-based recommendations and the standard for children's preventive health care in the United States. They promote a partnership between families and the healthcare team to address family concerns and allow for anticipatory guidance, which is timely and relevant. The implementation of the guidelines has been found to improve developmental screening and parenting interventions in a focused, family-centered manner. Family-centered care has also been found to increase anticipatory guidance and reduce unmet needs. This is where we as nurse practitioners, and particularly doctorally prepared nurse practitioners, have the opportunity to look beyond our individual patients and to look to the level of the organization and the system. In this case, the system was my patient, the problem was the lack of health education, and this was our proposed solution: to increase family-centered care by 30% by engaging in open communication with parents and guardians of children under 6 at the school-based health center over 90 days. The rationale for the tools we selected had to do with their applicability in other settings. For team engagement, we used a meeting agenda to effectively set goals and task follow-up. The Child Health and Adolescent Health Measurement Initiative Team Survey was utilized for child health quality improvement. The Consumer Assessment of Healthcare Providers and Systems child surveys were selected for patient engagement because they were successful in other pediatric settings. And as the practice had no wellness care model, the Bright Futures Guidelines were selected as highly effective and comprehensive pediatric health surveillance tools. They promoted family-centered care and provided tools for anticipatory guidance and wellness visit documentation. The model for improvement was used to plan rapid cycle quality improvement with 4 Plan, Do, Study, Act, also known as PDSA cycles, over the 90-day intervention through team engagement, patient engagement, form utilization, and wellness visit completion. The project improvement team consisted of myself, a health center administrator, preschool principal and deputy principal, and 1 teacher. All of the team members were highly motivated to bring change into the practice. It was also great to have a multidisciplinary team because the reality is, as educators, they're at the front line and they have daily interaction with the children and the families. Our baseline data collection began by reviewing student records and parent surveys with no comparison data available. A literature review identified implementation tools. Team engagement interventions, as previously mentioned, were the meeting agenda and a survey which measured team attitudes, capacity, and confidence towards the intervention. The patient engagement was planned through documentation of family concern at each visit and an experience of care survey which measured feelings of respect and partnership. The form utilization was planned with tools based on the Bright Futures Guidelines and anticipatory guidance documentation. And wellness visit completion was planned through the implementation of the Bright Futures periodicity schedule with a timetable developed to schedule appointments. During the 90-day project cycle, small tests of change occurred through 4 iterative or frequent PDSA cycles. The data was gathered by myself, the preschool staff, and the health center administrator through a series of Likert surveys for team and patient engagement, as well as chart audits. The team engagement was studied through the percentage of meeting agenda utilized, and patient engagement was both studied and measured through the documentation of family concerns. Form utilization was studied and measured through the percentage of wellness form used and anticipatory guidance documentation. Wellness visit completion was studied and measured by reviewing the number of daily appointments kept. The data was gathered and entered into run charts every 3 days by myself. The run chart analysis allowed for a dynamic review of the process to show replication and what led to the changes. The run charts were used to study outcome, process, and balancing measures, and the daily visit logs were reviewed for appointment completion. I measured all the data, and the daily appointment logs were compared to the number of visit forms to ensure that all were included in the data measurement. Qualitative data was obtained through surveys and discussions with staff and families during the project, and it was analyzed thematically. Quantitative data was entered into run charts for each measure, and visualization via run charts allowed for continuous interpretation over the intervention period with runs, trends, and out-of-control points guiding the tests of change. This was a non-experimental design quality improvement project, therefore it did not qualify for an institutional review board by Frontier Nursing University. Through the 4 PDSA cycles, the iterative quality improvement process occurred with small tests of change leading to improvement in nearly every measure. As you can see on the right-hand side of the screen, the only measure that we did not achieve was the process measure of daily wellness visit appointment completion. We did have some success of this, and some days we hit 100%, but it was not a change that was sustained over 50% by the end of the project. When we look at our team engagement, their capacity, confidence, and attitudes towards the project increased by 43.8% by the end of the project. During each PDSA cycle, additional staff members were added to the project. So this was really seen as quite a success as we saw their comfort level grow as the project proceeded with time. For patient engagement, we looked at the family's concerns regarding their child's health. During the first PDSA cycle, we began with children of staff members, and we originally had a 30% goal, but we actually achieved 80% documentation of family concerns in that first cycle. As the project proceeded, during the second cycle, we expanded to unemployed parents, and our concern documentation dropped to 66.7%. During the third cycle, we increased the number of appointments, and the documentation decreased to 54.1%. So we modified our goal to 50%, and during the final cycle, as a test of change, we asked about their concerns at the end of the visit, and we maintained that 50% goal. For anticipatory guidance documentation, we used 4 different wellness visit forms during that 90-day intervention due to the availability, user-friendliness, and utility to the practice. During the first PDSA cycle, we achieved 80% documentation, but we also had a very low number of appointments during that cycle. As our appointments increased and we used the forms more, we had constructive critique during that second PDSA cycle. It aided in identifying needs specific to the health center, which led to the use of 3 different forms during 1 week and 66.7% anticipatory guidance documentation. During this third cycle, we looked back and we saw we had hit a high point during the second PDSA cycle. We were already trialing a new form because one of our original forms became unavailable. So when we looked at the data trends, we noticed that we had superior utilization with the state of Maine form, and we had got documentation of 86.5%. So we increased our goal to 80%. And in the fourth cycle, we used that form exclusively, and our documentation surpassed 85%. We also added dental hygiene education and one additional anticipatory guidance topic. They were small tests of change in the final cycle, and we achieved 100% documentation. For our wellness visits during the first PDSA cycle, we implemented the Bright Futures Curiosity Schedule with staff members' children, with less than 2% of the total student body under 6 receiving wellness visits. As the project progressed, we expanded to unemployed parents and had more available appointments. And by the third cycle, we had a lot of success through word of mouth, and we had 14% of the student body receiving wellness visits. During the final cycle, we ended up achieving our 15% goal. The balancing measures of time and identification of developmental delays varied based on the circumstances of the individual patient and the need for translation. These measures served as baseline data for the health center with the initiation of wellness visits through the project. We were challenged by a total of 8 holidays during the 40-workday project. Several planned interventions were canceled due to other commitments or urgent events requiring staff focus, which resulted in missing data. One team champion who was instrumental in scheduling appointments was unavailable for several weeks during the implementation. And though other staff assisted, they didn't have the same rapport with parents nor familiarity with the intervention. We learned that there was some confusion amongst families regarding the emphasis of the intervention, leading to fewer scheduled appointments in the final weeks of the project. The interesting thing culturally about this is, if we think back to the beginning, we talked about the fact that families weren't included in healthcare decisions and didn't know about child development. Oftentimes, the interview format was a shift for them. It's not something that they're used to because they were used to really quick appointments. So we do suspect that this likely contributed to the confusion as well. The family-centered care and open communication were achieved through team engagement, anticipatory guidance instruction, and the implementation of wellness visits. Team engagement was achieved through a meeting agenda for task delegation and review of objectives, while attitudes, confidence, and capacity towards the project increased by 43.8%. The family experience of care survey exceeded predictions, indicating feelings of respect and partnership. The visit forms provided a framework for the visit, anticipatory guidance prompts, and family concern documentation. And we achieved our 15% goal of this 15% of the student body receiving wellness visit. Engaging families through anticipatory guidance instruction and asking about their concerns led to feelings of respect and partnership. These processes achieve the greater aim of family-centered care through open communication, which is consistent with previous studies which associate anticipatory guidance discussion with family-centered care. We found that not only could these tools be implemented in a low-resource setting, but there is the potential for unlicensed staff to be trained on these anticipatory guidance topics, which could result in a broader reach. This project provided tools to engage the team and families and provide a framework for preventive services. The project was perceived as beneficial, but we found that appointment scheduling was central to the rest of the outcomes. And the early success was likely due to the small sample size and easily accessible population. As the project progressed, we learned that it was difficult to access working families, and further tests of change are needed to determine a solution for our context. The tools used for the intervention were available for free online, apart from the Bright Futures guidelines, which were purchased for a nominal fee. In our context, it's difficult to perceive a strategic trade-off, as the project was a means of beginning preventive services. Likewise, opportunity cost is challenging to measure, but it is reasonable to assume that the preschool staff made modifications to their schedules to assist with the project. The ability to generalize our project may be limited as a private school-based center in a previously disadvantaged area. We had more time to dedicate to the project than may be available in the public sector. We were hesitant to promote the intervention large scale for fear of not being able to accommodate 250 visits in the project period. The decrease in family concern documentation may reflect that it is acceptable for there to be no concerns, or that rapport must be established for them to be shared. We attempted to address this during the visits by asking about concerns later in the appointment. This project showed that family-centered care through wellness visits fosters open communication and anticipatory guidance. The meeting agenda, visit forms, surveys, and periodicity schedule were useful to the practice. The free tools make this project financially sustainable, and the intervention is currently planned for scale-up. Appointment scheduling could be improved through daily huddles and information sessions to promote the intervention to teachers and parents. Identification of developmental delays will help to refer children for necessary services. The intervention has the potential to support family health education in the public sector as well. The team is interested in applying other guidelines that are part of Bright Futures in adding developmental screenings. There was no outside funding received for this quality improvement project. I'd like to leave you with this. Mary Breckenridge was mission-focused and can inspire us to answer the call and reach wide neighborhoods with family-centered care. Thank you.